Hello, my name is Yenifer Thompson. I am a third-year clinical psychology doctoral student at the University of Houston, and I'm here today to present on my recent publication that is titled Evidence for Neuropsychological Health Disparities in Black Americans with HIV. I am honored to have been selected as the first place student competition winner for the TCN AACN competition, and I am very grateful to the committees who considered and selected my project. I would also like to take a moment to thank my co-authors and my mentor, Dr. Stephen Woods, who supported me during this project as well. And for those who are interested in reading my paper, it was recently published in the TCN 2022 special issue, Do Black Lives Matter to Clinical Neuropsychologists? To introduce this research topic, I will first discuss some relevant literature. So first, there is a stark overrepresentation of Black Americans in the HIV epidemic. There are structural inequalities that might combine to increase HIV transmission and infection rates for Black Americans, such as cultural stigmas and higher rates of incarceration. There are also historical atrocities and racism in the medical system that may have contributed to medical mistrust in the Black community that could further decrease engagement with HIV prevention and detection behaviors. Also, Black persons with HIV are faced with multiple systemic challenges that have serious adverse consequences that could increase the risk for other health comorbidities and higher mortality rates. Additionally, there are racial disparities in the measurement and diagnosis of neurocognitive disorders that might also exist among Black Americans more broadly. And this is evidenced by findings across studies of poor neuropsychological performance in multiple domains of cognition. And this reduced performance might be related to things like stereotype threat or perceived discrimination, economic disparities, also things like lower education quality for Black Americans despite commensurate quantity of years of education in school, and also individual differences in health literacy. So previous studies have found relationships between those variables and poor neuropsychological outcomes among Black Americans. So altogether, the existing literature suggests that these factors may combine to increase the risk for neuropsychological disparities for Black persons with HIV. However, it's not yet entirely clear whether these effects are additive, synergistic, or similar across different cognitive domains. The literature suggests that Black persons with HIV may have poor neuropsychological outcomes and have significantly greater likelihood of clinically determined neurocognitive impairment when compared to their white counterparts. And these disparities are important because they may contribute to negative downstream effects on things like medication management and greater dependence in everyday functioning. However, we need more research to understand how the expression and correlates of neurocognition and everyday functional problems among Black people with HIV. All right, so this leads me to the purpose of my current study. And the goal of my study was to answer some of these remaining questions. So the first aim was to investigate how race and HIV serostatus individually and together impact neuropsychological functioning. And for this first aim, we predicted that Black people with HIV would perform lower on the neuropsychological battery, and particularly in the domains of memory, executive functions, and processing speed based on previous findings that these domains are implicated in HIV. The second aim was to examine whether rates of neurocognitive disorder by race and HIV serostatus are different, essentially. And so we predicted that Black people with HIV would have the highest rates of impairment. The third and final aim was to investigate the relationship between cognition with HIV markers and everyday functioning among people with HIV only. And we predicted that worse neurocognition would relate more strongly to HIV markers and functioning in the Black people with HIV group. The study was comprised of 215 individuals who were between the ages of 18 and 66, and they were in one of 4 study groups based on Black or white race and by HIV serostatus. And these 4 groups allowed us to employ a full factorial design for the study. The 4 groups were matched on age, education, substance use history, and hepatitis C virus. And additional sample characteristics are shown in this table for those who are interested. All participants were administered a comprehensive neuropsychological battery that assessed the 6 cognitive domains that are listed here. Raw neuropsychological scores were converted to sample-based Z-scores to examine the unique and combined effects of race and HIV disease on neurocognition. And the use of raw scores converted to Z-scores was done to reduce the influence of demographic normative adjustments. Everyday functioning was measured using 5 different subjective measures. Our second aim was to determine whether HIV and race influence rates of neurocognitive disorder diagnoses. And given that many clinicians use race-adjusted norms when diagnosing neurocognitive disorders, we used normed neuropsychological scores to determine clinically significant impairment for this aim. So individuals who had intact neurocognition and functioning were classified as not impaired, and persons with neurocognitive impairment only were classified with subsyndromic neurocognitive disorders. And finally, syndromic neurocognitive disorders were classified if an individual had both neurocognitive and functional impairment. And these diagnoses were consistent with the Frascati criteria for HIV-associated neurocognitive disorders. A quick note here for our data analysis. Covariates were determined if they significantly related to both the independent and the dependent variables in each model. So this was a confound-based approach. The study had adequate power to detect a medium effect size given the sample size, and we used a critical alpha of 0.05 for the primary analyses. So let's get to the results. And apologies, I'm covering this question, but this is just a reminder of the first aim, which was asking whether race and HIV interact to affect neurocognition across the domains. So we conducted a repeated measures MANOVA to examine the relationship between HIV serostatus, race, and performance across the 6 domains. In this model, we covaried for estimated IQ, a positive THC screen on the day of testing, self-reported mood disturbance, and number of medical comorbidities. The overall MANOVA model was significant. However, no main effects of HIV or race were found, and the HIV by race interaction was not significant. However, we did find a significant 3-way interaction between HIV, race, and neurocognitive domain. So planned post hoc analyses were then conducted to compare the neuropsychological scores between the 4 study groups within each domain. And we did this using a 1-way ANOVA, and then significant ANOVAs were followed up with all pairwise comparisons. And we used a Tukey-Kramer HSD correction to reduce the risk of type 1 error. In the semantic memory domain, Black persons with HIV had lower scores than both white persons with HIV and seronegative individuals, and these differences were at medium to large effect sizes. Black people with HIV also scored lower than white people with HIV in processing speed at a medium effect size. And finally, group differences in the domains of attention and episodic memory were observed, and these were actually driven by significantly higher scores among white HIV negative individuals as compared to both white and Black persons with HIV, and these differences were at a large effect size. Interestingly, there were no differences observed for motor skills, and then contrary to our hypothesis, there were no significant group differences, and especially not a lower performance among Black persons with HIV for executive functions. Then for the second aim, which was looking at whether HIV and race combine to increase risk of greater neurocognitive disorder classification. So to examine this analysis, we conducted a logistic regression to determine whether HIV serostatus, race, or their interaction were associated with clinical classifications of neurocognitive disorders. And here we included lifetime affective disorder, estimated IQ, and positive THC screen as covariates. The race by HIV interaction fell at the level of a trend here. See that P of 0.051, so we're very close. And so based on that, we decided to conduct post hoc chi-square analyses to examine what was driving this trend level difference. And we actually found that greater rates of both subsyndromic and syndromic neurocognitive disorder classifications were observed for Black persons with HIV as compared to the other 3 study groups. And you can see that difference quite starkly here in the figure. Notably, rates of neurocognitive disorder classifications did not meaningfully differ between the Black and white HIV negative groups. And this suggests that race differences among the people with HIV were not an artifact of the race-adjusted norms. So we can't just attribute it to that. For the third and final aim, we examined the association between global neurocognition with HIV disease markers and with global everyday functioning among the people with HIV only. So we conducted correlations within the Black and white people with HIV groups separately. And there were no significant correlations between any of the HIV markers, including CD4 count, AIDS status, and viral load. So no significant associations with those markers and cognition in either study group. However, really interestingly, in everyday functioning, we found there was a notable difference such that global neurocognitive Z-scores had a very small and non-significant correlation with everyday functioning among the Black people with HIV. Whereas you can see here, there was a moderate negative correlation observed among the white persons with HIV. And this is suggesting that perhaps something other than cognition might be driving functional problems in the Black people with HIV group. And you'll see here also the correlation was significantly different among the groups. So definitely an interesting and unexpected finding. So what are the main takeaways? So to our knowledge, this is the first study to use a full factorial design to show that HIV disease has a disproportionate effect on neurocognitive functioning for Black Americans. And these effects were notable in the domains of semantic memory, and this aligns with previous findings in the literature. However, it's worth mentioning that language tests in neuropsychological batteries, such as the Boston naming test, might contain cultural biases or cultural insensitivities, especially given that these tests were developed by, in, and for white individuals. So that's something to definitely consider and keep in mind. We also found that speeded information processing was slower among Black persons with HIV. And this also matches with previous findings, but it is worth considering in the interpretation that processing speed is a societally driven construct, and it may be inherently biased towards white individuals. So we definitely have to be careful of some of those inherent biases in our measures that might be driving these lower scores in Black persons with HIV. Also, we did not observe worse functions for Black people with HIV in episodic memory. So you'll remember it was just the white HIV negatives that did better than everyone else. And this was surprising given that episodic memory is historically very sensitive to HIV disease. Also, a previous study found that social adversity in the context of HIV was linked to reduced volume in the hippocampus and the amygdala, and that was related to poor learning and memory performance. So when we were reviewing and interpreting our findings, we thought maybe it was the case that both white and Black persons with HIV in the current sample experienced social adversity related to their HIV status. Also, the null group level differences in executive functions was also surprising and contrary to our hypothesis. And previous research has found effects of HIV or effects of executive functioning in HIV. But one study found that this effect was actually minimized after the authors accounted for race and education. So maybe after controlling for those variables, maybe there are no differences in executive functions. So that's one thing we took into consideration. And another thing that we looked at and found in the literature is that women with HIV tend to demonstrate greater problems with executive functions. And our sample was predominantly men, so maybe that's part of the reason why we missed an effect of executive functions. So ultimately, we recognize that there is definitely a greater need for more representation of Black individuals in research and new assessments to be developed for diverse groups in order to better assess these constructs and to work to reduce the racial biases that are inherent to many of the tests used today. There we go. We also examined the clinical implications of these raw score findings by looking at whether race and HIV combine to impact rates of HIV-associated neurocognitive disorders. And although a number of tests in this battery were actually normatively adjusted for race, which could arguably increase our risk of type 2 error, we still found a trend level interaction between race and HIV status. Such that neurocognitive disorder frequency differed between the groups and was especially high in the Black persons with HIV. Also, nearly half of the Black persons with HIV in our sample met criteria for a neurocognitive disorder, and then half of that group was classified as syndromic or functionally impaired. So this leads us to believe that there may be some systemic disadvantages for Black individuals that are exacerbated by HIV disease to have synergistic effects on clinical neurocognitive outcomes. And future work is needed to explore whether factors such as healthcare discrimination, acculturation, or education quality are contributing to these disparities. Often race is considered maybe a nuisance variable or something we just include as a covariate, but our findings really suggest that there are some systemic factors and contextual factors that negatively impact Black individuals that really warrant further investigation to understand why these negative outcomes are showing up clinically. And finally, perhaps the most intriguing finding from the current study was that lower raw neuropsychological test scores were not associated with worse everyday functioning for Black persons with HIV. So this suggests that perhaps beyond cognition, other barriers that are unique to or amplified in Black people with HIV might interfere with functioning, such as structural barriers, perhaps food insecurity, social adversity, and HIV stigma. So ultimately, more research is needed to ask and investigate these important questions so that we may better understand what is driving the functional problems for Black individuals and to provide opportunities to intervene and help. Okay. So I will conclude with mentioning some limitations of the current study. And as we all know, limitations can often highlight areas for future research. So first of all, the current sample was not representative of Black women, older adults, or people from highly affected areas in the US, such as the Southern US. And that's to say areas highly affected by HIV disease. Also, there were no measures of experiences with discrimination or perceptions of discrimination given this was a retrospective study with our archival data, so we couldn't really choose to add those measures, unfortunately. Also, several neuropsychological tests used here rely on older normative data that was developed within predominantly white samples. And this may limit the construct validity and increase the risk of inherent biases for assessment in Black Americans. And so this really highlights the need for future research to develop and validate relevant assessments within culturally and racially diverse populations. And this will hopefully help increase their acceptability, applicability, and sensitivity for clinical purposes. Everyday functioning was only assessed via self-report, and so future studies might benefit from using performance-based functional assessments to better understand functional outcomes among Black persons with HIV. Neuropsychology as a field really needs to be conscious of using modern community engagement efforts to recruit, enroll, and retain Black people with HIV and at-risk seronegatives in our research to ensure representativeness. Our sample showed that we had a sufficient number, but it was the smallest group compared to the other study groups. And so we definitely need to improve our efforts to enroll Black individuals so that we can better understand the problems that they face and how we can help. And finally, the identification of these racial disparities requires further efforts to help reduce these neuropsychological problems among Black persons with HIV, as I have said. And some methods could be investigated for interventions, such as increasing cognitive reserve through spaced retrieval practice and possibly training speed of processing. So these are previously explored interventions in HIV populations. And so these could be good starting points for future examination to specifically uplift and help Black persons with HIV who may be having neuropsychological difficulties. Thank you all so much for your time and for coming to my presentation. I really appreciate your attention, and thank you again to the committee for selecting this paper as the student competition winner.